Right, so MEDI1191 from AstraZeneca is an IL-12 construct. It's a locally injected agent that's open in a phase 1 clinical trial for all solid tumors. It has a couple of cohorts. It's combined with anti-PD-L1 Durvalumab, and it's looking at patients who are checkpoint naive or checkpoint experienced, and looking to answer a couple of questions. Number one, is this safe and tolerable, which so far we've seen it has been. Number two, can we see responses? And we have ongoing responses in a whole host of solid tumors. For us at the Angeles Clinic, we've seen a response in a heavily pretreated cutaneous melanoma patient who had seen anti-CTLA-4, anti-PD-1, and TVEC. And we've now seen an extended partial response that's deep and durable and ongoing. So the first part is a phase 1 portion looking at whether you need a run-in with this agent and then the Durvalumab, or giving them concurrently. And then there is another subgroup that's looking into visceral injection of this interleukin-12 construct. That, I think, is important in all solid tumors as we think about immunotherapy, because as we've published and presented with Matt Hellman and Adil Dowd of Memorial and UCSF and Tony Ribas of UCLA, patients with solid tumors that respond to PD-1 therapies, pound for pound, do worse if they have hepatic visceral disease. And if you can get in there and do something locally to elicit an immune response, sort of like the previous ideas about priming and boosting, then we can solve that paradigm. And what we've seen so far in our initial cohorts is very safe, tolerable, and some early responses. Again, going based on what is now coming to fruition, not just checkpoint inhibitors, not just PD-1, PD-L1, but coming back to understanding our interleukins and how they can help us to initiate a response, to take a cold tumor to a hot tumor, to take a primary refractory or relapsed PD-1 patient and give them the benefit of the next line of therapy.